Comprehensive Airway Evaluation in Anesthesiology, a deep dive for medical professionals. Welcome to our podcast, where today we'll be exploring the fundamentals of comprehensive airway evaluation in anesthesiology, a critical aspect for every practitioner in the field. If you're tuning in as a trainee, a seasoned expert, or simply someone fascinated by the intricacies of medical practice, this episode is for you. Why airway evaluation matters. Let's begin by underscoring the importance of a thorough airway assessment. Predicting and managing challenges such as difficult mask ventilation, laryngoscopy, and intubation can mean the difference between routine success and life-threatening complications. Recognizing a difficult airway in advance helps us prevent hypoxia, brain injury, or even fatal outcomes. Objectives of a structured airway assessment. Our primary goals are clear. Anticipate difficult mask ventilation, DMV. Identify potential difficulties with laryngoscopy and intubation. Evaluate the feasibility of using supraglottic airways, SGAs. Plan for alternative approaches. Think video laryngoscopy, fiber optic intubation, or surgical airway access. Minimize surprise complications and improve patient safety. Breaking down the airway assessment. Now, let's walk through the essential components. A. Patient history. Start by asking about any prior issues with intubation. This remains the single most predictive factor. Dig into relevant conditions such as obstructive sleep apnea, OSA, rheumatoid or ankylosing spondylitis. Think neck mobility, head and neck cancers, radiation fibrosis, airway or subglottic stenosis, symptoms like stridor, hoarseness, or dysphagia, recent airway infections. B. Physical examination. Let's move to the exam. Begin with a general inspection. Look for facial anomalies, micrognathia, retrognathia, or beards can all pose challenges. Assess the neck. Is it short? Is there a large tongue or mass? Check dentition for prominent incisors, loose teeth, or dental appliances. Now, let's discuss specific bedside tests to predict airway difficulty. Start with the Malampati score. Ask the patient to open their mouth and stick out their tongue without making a sound. If you observe only the hard palate or the base of the uvula, Class 3 or IV, anticipate increased airway difficulty. Next, measure the theromental distance, which is the distance from the thyroid notch to the tip of the chin, mentum. If it's less than 6 centimeters, this suggests a challenging airway. Similarly, the sternomental distance, measured from the sternal notch to the mentum, should be greater than 12 centimeters. Less than this also signals possible difficulty. Assess the mouth opening by measuring the gap between the upper and lower front teeth. The interincisor distance. A gap of less than 3 centimeters can make airway management more difficult. The upper lip bite test is another useful tool. Ask the patient if they can bite their upper lip with their lower teeth. If they cannot, designated as Class 3, this indicates a higher risk of difficulty. Neck mobility is also crucial. Ask the patient to extend their neck, aiming for more than 35 degrees of extension. Limited movement here is a warning sign. Lastly, consider the Wilson risk score, which takes into account factors such as the patient's weight, neck movement, jaw structure, chin, and dentition. If 2 or more risk factors are present, the likelihood of airway challenges increases significantly. Predicting difficult mask ventilation. The Beard's mnemonic. Memorize the Beard's acronym for common predictors. Beard, facial hair, elderly, over 55, apnea or OSA, receding jaw, dentures, snoring or obesity. Grading laryngoscopic views. Cormac Lehane explained during laryngoscopy, the views are typically classified into 4 grades. Grade I is when there is a full view of the glottis, making intubation straightforward and usually easy. Grade 2 is characterized by a partial view of the glottis, which can make intubation moderately challenging. In Grade 3, only the epiglottis is visible, and no part of the glottis can be seen. This scenario is difficult and often requires adjuncts or alternative techniques. Grade IV is the most challenging, where no glottic structures are visible at all, and alternative intubation strategies are strongly advised. Remember, the modified scale includes IIA, partial chords, and IIB, arytenoids only. Special populations and considerations. Pediatric airway, larger tongues, floppy epiglottis, anterior larynx, and a cricoid cartilage that's the narrowest point. Uncuffed tubes are often selected for this group. Obesity and OSA. There's heightened risk for rapid desaturation and more challenging airways. Don't forget the Rampton criteria for OSA screening. Trauma and C-spine injury. Avoid neck movement. Think video or fiber optic scope. Secure C-spine clearance when possible. Advanced assessment tools embracing technology. Use ultrasound. Assess hyomental distance. Subglottic diameter. Leverage 3D CT MRI for complex anatomy. Consider virtual endoscopy for detailed pre-surgical planning. What if you anticipate a difficult airway? Awake intubation. Fiber optic bronchoscopy remains the gold standard, but video laryngoscopes are proving invaluable. Blind nasal intubation is rare these days. Emergency surgical airway. Know your needle and surgical cricothyrotomy techniques. When seconds count, preparation saves lives. SGA rescue. Devices like LMA or iGel can be life-saving if intubation fails but ventilation is possible. Documentation and teamwork. Never overlook the importance of meticulous documentation. Record all findings, Malampati scores, distances, any red flags. Proactively inform your team if you anticipate challenges, and always have a backup plan ready, from a difficult airway cart to an extra anesthetist. Final thoughts to wrap up. A structured airway evaluation safeguards your patient and your team against high-stakes complications. Remember, start with a detailed history and targeted physical exam. Stratify your risk thoughtfully. Be prepared with advanced tools and backup plans. Thanks for joining us on this episode. For more in-depth discussions, be sure to subscribe and tune into our next podcast on intravenous anesthetic agents. Until then, stay curious.